I'm Chad Hamill. I'm an associate professor in the section of liver and pancreas surgery. And today I'm presenting our big idea, which is remote telemonitoring to improve outcomes in surgery patients. Pancreas surgery is prone to complications due to some specific properties of the pancreas. 40% of patients that have pancreas surgery will develop complications. This is obviously costly to the healthcare system and detrimental to the patients. The national average for the cost of pancreas surgery is $31,000 in patients who don't have complications. However, in those patients that do have complications, the cost almost triples to $89,000. This is despite years of trying countless different surgical and pharmacologic techniques to reduce the complication rate. It's been stable for decades. So obviously, new and innovative strategies are needed. And since changes in surgery haven't worked, we're focusing on the period before and after surgery to remotely monitor these patients to try to improve outcomes. The wide adoption of of activity trackers allows the remote monitoring of patients. And machine learning has the potential to process and interpret the large amounts of data we capture without overwhelming the healthcare team. Commercially available, inexpensive activity trackers can currently track step data, active minutes, heart rate. And using the Fitbit platform, we've demonstrated that we can remotely monitor this data in patients. We've assembled a team. My expertise is in the clinical area. Elizabeth Pratt is the director of the Enhanced Surgery Recovery Program, and Dr. Cheng-Nan Liu is a professor of surgery with expertise in machine learning. He's performed a previous study in congestive heart failure patients. It was 25 patients. They were 88% compliant with wearing the telemonitoring devices, and the machine learning algorithms were 96% accurate in predicting complications. Our goals are to provide preoperative, objective, and more accurate assessment of the patient's functional status with activity tracking, to increase mobilization during the in-hospital stay with predefined goals and objective tracking of those goals, and finally to determine with whether remote telemonitoring and machine learning can provide early warning of complications of patients in the outpatient setting. Thank you.
So are there any preliminary evidence to suggest that early mobility has any impact on specifically pancreatic? I mean, one can imagine that for congestive heart failure, predicting outcomes, activity is very correlated with outcomes. But in pancreatectomy patients, is there any reason to believe that there is a similar correlation?
There's a lot of data that enhance recovery after surgery protocols, which is, they always include early mobilization, improves outcomes, but nobody kind of has been able to study it individually because it's incredibly hard to track. Currently we kind of put, 3 walks on the board and they check it off, but nobody's measuring distances or quantifying that anymore. So there's some thought that there's some data, but the data is really bad.
So when you think about telemonitoring, are you thinking of this as remote, as a continuous or episodic contact with the data collection?
I mean, it's the heart rate is pretty continuous, but it is somewhat episodic. But it's every 5-minute heart rate data, and every couple hours activity data. So it's not technically continuous, but it's pretty frequent.
So do you have any idea of things, it's almost a tautological question, of unknowns that are going to be predictive of these outcomes? You obviously have talked about activity and heart rate and other things that we can measure directly. But then you invoke the famous machine learning AI that everybody has to doing an innovation of that. And that's assuming that there's something we don't know about that might be even more predictive. Do you have any early hypotheses about what that might be?
I mean, outside of heart rate and activity, which are easy to track, I definitely think temperature fluctuations would be an area that would be worth looking at, just, thinking about the process of infection and inflammation, which is usually the complication we're dealing with. So if I had anything that I could easily monitor, it would probably be temperature, but I don't think we know at this point.
So I feel like I'm channeling Tom because I keep on asking a question that's somewhat repetitive in terms of this critical issue of what are you going to do from an intervention strategy with this, right? Much like Tom likes to say, what problem are you trying to solve? My favorite is you monitor these signals, you find a way to predict those patients that are, potentially not progressing as you would expect post-surgically. Then what do? How do you change sort of the trajectory for those patients based on this data?
So I think this is an easy one for us because the most common complication is basically leakage of the pancreatic enzymes. Those enzymes build up in the abdomen, and eventually that collection of enzymes gets infected. Usually, we've tried, calling the patients, catching these things early. If you do, for whatever reason, catch this early, the patient goes, gets a drain put in an outpatient setting, they never get septic, they go home, the drain comes out. It's a pretty mild course, but generally what happens is the patient gets septic, they get admitted through the emergency room, they go to the ICU, they get resuscitated, they get antibiotics, they get a drain put in, and 2 days later, they're, pretty much back to normal. So, there's this potential to, reduce a lot of cost, prevent a lot of healthcare utilization in this case, I think.
What's the duration of time you anticipate tracking people for before and after?
So we want to do 2 weeks before and 30 days after, because that's, the after. We want the before as kind of a baseline, but it also, right now we try to assess patients, how well they're going to tolerate surgery. We do the 6-minute walk test and all these things are really core. But we really want that preoperative data for, baseline data to compare the postoperative to. So we're going to do 2 weeks and then 30 days. Most of the complications kind of happen early in the hospital stay or in about 2 weeks. So if we think, 30 days will catch most of them.
So building on what you just said, when most of the complications occur, what do you think a positive impact on the threefold difference between complications and no complications and cost might be?
So it's all that stuff I talked about. I mean, when you look at the data, most of the cost is in antibiotics and things like that. But it's that ICU, it's that emergency room visit, the ICU admission, and the inpatient antibiotics and those things, as opposed to an outpatient procedure that is much less costly. So that's what all that costs is.
I'm scared to ring this bell now.